Okay, hello everyone, and welcome to CPD webinar series. Today we have had great interest actually in this webinar, and I think it shows that ECG is a very important topic, something that obviously we see on a daily basis, and non-cardiologists always a challenge. So we have two excellent cardiologists today. My friend Dr. Saqib Ghani, my classmate from Dow Medical College, and we have other colleague, Dr. Yawer, Saeed, joining later. So this is going to be an interactive session. And those of you who are not able to attend, because we cap at 100 registrations. So if you are unable to attend, then you can always watch a recording on our YouTube channel afterwards. So without any further delay, I would like to invite Dr. Saqib Ghani. He has some polls and questions as well, so to keep it interactive. So over to you, Saqib. Thank you.
Thank you very much, Mansoor and Naseem, for your kind invitation. Can I just confirm if you can see my full screen?
Yes.
Okay, so I'm Saqib Ghani. I'm an intervention cardiologist at Dan Valley Hospital in Dartford, which is just at the outskirts of London. But as Naseem has alluded, I've studied with Naseem and Mansoor back in Dow Medical College, and we share lovely memories. So what are we here for today? The objective of today's session is it's actually aimed at non-cardiologists. So I'm not going to bore you with too much detail of cardiology itself. But what we want to do is review some interesting ECGs or some common ECGs, have an interactive session where if you can't unmute, at least you can text in the chat box, or there'll be some occasional polls coming up where you can answer anonymously. And I've grouped a few ECGs together, and then there are some slides with take-home messages, because that's probably the most important thing. Everyone should learn something from every ECG. With no further delay, I'm going to move to this first ECG. So what I just want you to do is have a look at it. I've left the numbers on the top as they are. I don't know, the audience may have very junior doctors, some more senior, some even more better than me at reading ECGs, so I have to be careful here. But this particular ECG, I just want to tell everyone that no matter what the ECG shows, you should go through a certain scheme. You should look at the heart rate, rhythm. You should make sure it's regular or irregular. Check if there's a P wave followed by QRS every time, because that basically defines the normal sinus rhythm. Check if the QRS duration is normal. See if there's RF progression. When I say RF progression, that means negative in V1, V2, moving towards positive in V5, V6. That's called normal RF progression. Okay, and then you look at T waves and ST segments. So this is just a general tip to anyone who's learning how to interpret ECG. It's like a driving test. You have to tell the instructor that you're looking at different things. You're doing the maneuvers.
Saqib, are you showing the ECG, because your slide is not moving?
I'm showing the first ECG.
No, we can just see the first slide.
Yes, sorry, Saqib, your slides are not moving.
Really? Okay, one second.
I thought you were just giving a prelude.
No. Okay, hold on. Let me stop share and then start share again. Then it might work. Just give me a second.
Yeah.
Okay, what can you see now?
Yeah.
Yes, we can, yeah.
Have I gone back to objectives? Can you see that?
Yeah.
I'm back to the ECG. You can see that?
Yeah.
Okay, thank you so much. So sorry about that glitch. But this first ECG is just to tell you there's a pattern. Everyone should develop a pattern and follow the pattern. So there's nothing tricky about this one. In the text message or by unmuting, some of you can shout out, do you think this is a normal ECG? Just tell me yes or no. I've not given any clinical information yet.
I've asked to unmute all. So if anybody wants to, so Faria Wasim saying yes.
Yeah, someone in the chat box saying normal, okay. Or I'll make it easy. Is there anyone who thinks it's abnormal? Please speak out, let me know. No answers, I will assume it's normal, and I'm happy because this is normal. This is actually my ECG. So I'm glad everyone agrees it's normal. Okay, I'm now going to add some clinical information to it, because ECG on its own means nothing. So based on ECG number 1, now we can mute everyone. Let's see, make sure they're all muted. 58-year-old male with exertional chest pain relieved with rest and GTN spray, and the pain radiates down the left arm or associated with sweating. This has been worsening for the last 3 months, but no symptoms at rest. He has history of hypertension and borderline raised cholesterol, he has been a smoker for 20 years, and there is family history of ischemic heart disease. So a lot of risk factors there. What should you do? This is about the ECG number 1, which I showed you just a moment ago, this ECG. So it's a normal ECG. This is the clinical history. I have given 4 options. Mansoor, can you launch poll number 1 for ECG number 1, basically?
Okay, I'll do that.
So the audience, you will be able to see some questions and you can answer them on your screen, whether it's your mobile device or your laptop. And once you have a few answers, we will see where we're going with it. So that's good. You know, this feels like election results coming through, you know.
Yeah, I can see that.
That's good. 50% people have answered. All of you, keep going. We'll wait for another 10 seconds. And then Mansoor, you can stop and share the results to just see what the trend is. Okay, let's see, Mansoor. Right, so nice mix. 10% are saying ECG is normal, so nothing to worry. Some are admitting, 20% almost, but majority are saying start the tablets, but bigger majority is refer to cardiology for outpatient assessment. Now, my answer, if you ask me, I will select the last 2 options because I think they both are correct. Let's just stop sharing the results. Are you sharing the results here?
I've stopped it.
Share.
Ah, you didn't share them earlier. Now we're sharing them. Okay. So now everyone can see, right? Most people have gone for refer to cardiology as an outpatient. About 30% are saying start treatment with aspirin, beta blocker, statins. 20% are admitting the patient and 10% are saying nothing to do. I would go with the last 2 options. These both, in my opinion, are correct. Why do I say so? Well, firstly, can you take this poll away, Mansoor, from the screen?
Okay.
Yeah. It's gone, yeah?
Yes.
Is it gone? It's still coming on?
No, it's gone. We can just see a slide. ECG.
Okay, okay, fair enough. So the reason being, patient does not have pain at rest. So it's stable angina. And therefore, I think routine assessment is fine, but we should start treatment in the meantime. I think routine assessment will be fine in this case. Right, I'll move on. Can you see ECG number 2?
Yes.
Okay, so here I've given you some clinical history that this gentleman, make it 70 years old if you like him, has had chest pain for the last 2 hours. Have a look at the ECG just for a moment. See what you think about it. And then in the chat box or by unmuting yourself, tell me what you think is abnormal with this ECG. Anyone can?
I'm saying ST elevation in lead 2.
Lead 2, okay, that's right. Anybody else? So I'll start off with some basics anyway. This is sinus rhythm. There is P wave. It's a regular rhythm. I agree. There is ST elevation in lead 2. Anything else?
Inferior lateral STEMI. Narankari saying. Mohsin
Okay,
saying
inferior lateral STEMI. What about ST depression? Can you see some ST depressions as well?
Yeah. Mohsin Khan saying ST depression in V1.
V1, okay. What about V2 and V3?
V3 as well.
Which one, sorry?
V3, that's ST depression in V3.
ST depression. So that's good. You've picked up the changes. Do you think this is anterior non-ST elevation or this is inferior ST elevation? What is this? Okay, why don't you launch the poll
Anterior inferior.
for ECG number 2?
Okay, we'll do that in a second. Yeah. It has been launched.
Okay, so we have some options here. You treat this patient as acute coronary syndrome or NSTEMI. You can give him aspirin and ticagrelor or clopidogrel. You can thrombolize him, which is the last option. You can refer for outpatient assessment or admit him through medics and check troponin levels. I'm just going to wait for 15, 20 seconds and see what kind of answers we get. I like the interaction. I like the fact that everyone is trying to contribute. That's good. Okay, let's look at the answers, Mansoor. Let's stop the poll. and share the results, please? Yeah. Okay. So just under 10% are treating as end-STEMI. I think they're looking at the anterior leads, V1 to V3. 8% are saying give aspirin ticagrelor. That is the right thing to do anyway. I'm glad no one is waiting for outpatient assessment here. That's good. Some of you saying admit via A&E and check troponin. Not a bad answer, but 30% who said call tertiary center for emergency PCI. That is actually the right answer. And then thrombolysis, which may be right answer depending on where you're working, because I have audience here from various parts of the world. In some places, emergency PCI might not be available, in which case thrombolysis will be applicable. But the correct answer as per protocol will be emergency PCI. Let me focus here. This particular answer, that's why I put it here. Refer to medics for admission via A&E and check troponin. Can you just stop sharing?
Okay.
Yeah. And why is that not the right answer? Because we are here dealing with posterior STEMI or inferior posterior STEMI. This is not anterior non-ST elevation MI. This is actually posterior ST elevation MI, which looks like ST depression in V1 to V3. In the next slide, what I'm going to do is, imagine you have ECG in your hand and you flip it upside down. That's what it's going to look like, the same ECG. Now, if you look at leads V1, V2, V3, can you see how obvious the ST elevation is? I'll go back. This is the original ECG. And if you just flip it upside down, the reason is posterior aspect of the heart is not seen by any ECG leads because the ECG leads are attached anteriorly. So a posterior ST elevation MI mimics anterior non-ST elevation MI. Now in this ECG, there is ST changes in inferior leads anyway. So that will take in priority. So this should be treated at ST elevation MI, okay? So that's ECG number 2. And one more ECG before I'll give you take-home messages. Everyone can see full screen, or you're looking at the poll in front of you?
Full screen, Saqib.
Full screen, okay. So clinical scenario of 67-year-old lady who was previously had aortic valve surgery, had chest pain for about 15 hours, was very sweaty, clammy, and unwell, presented to hospital with blood pressure, which was very low, requiring inotropic support. So even without showing the ECG, we think this patient is very unwell. This is a real scenario, all the ones I'm sharing, and this particular one is the one I dealt with. So this is the ECG which was emailed to us first thing in the morning. Just have a look. There's no poll attached to this one. So you can speak up or you can type in the chat box. What is it that you're worried about here? Or is there something to be worried about? You can unmute and speak as well. I don't know if the system is allowing you to do that. So admins, if there's something in the chat box, I can't see that. Do let me know if someone answers.
No, not yet, Saqib.
Not yet. Anyway, this is, to summarize, this is a grossly abnormal ECG. I think everyone will agree. There is widespread ST depression, inferior leads, anterior leads, lateral leads, everywhere. But one other important bit I want you to look at and focus on. In a 12-lead ECG, there are 6 limb leads and 6 chest leads. The 6 chest leads and the 5 limb leads, which are 1, 2, 3, and AVL, AVF, these are territorial ECG leads. What about AVR? AVR is like a 12th man in a football team or a cricket team. It doesn't do much, but when it is brought onto the field, when it becomes active, you think something big has happened. So when you start to see ST elevations in AVR, that often is a sign of left main stem disease. Okay, so coronary arteries, there are 3 of them: LAD, circumflex, and RCA. But LAD and circumflex originate from left main stem. And if you have a critical issue with left main stem, you can have this kind of ECG, grossly abnormal, ischemic everywhere. So this lady basically was cardiogenic shock, which is a poor prognostic marker. She had left main stem coronary dissection, which caused widespread cardiac ischemia with severe LV impairment. Immediately after the angiogram, she went for bypass surgery with balloon support, but unfortunately did not make it despite having urgent surgery. So this was one of the extreme ends of coronary ischemia. So what are the take-home messages from leads 1, this ECG 1 and 3, 1 to 3? One take-home message is that normal ECG at rest does not rule out coronary disease because angina is a clinical diagnosis. It does not need any test to diagnose it. But in the presence of chest pain and ST changes, don't forget that time is muscle. and emergency coronary revascularization or urgent PCI is recommended within 2 hours. And one more thing to remember is posterior ST elevation can be missed even by experienced clinicians. So watch out for what appears to be anterior ST depression. Okay, so anterior end STEMI will usually present with T-wave inversions. But if you've got marked ST depression with positive upwards V1, V2 R complex, that suggests posterior. So just think about it. You'll only know about it if you think about it. Okay, let's move on in the interest of time. So ECG4 is a 56-year-old male who's fit and healthy, wears a smartwatch during exercise sessions, and occasionally a smartwatch says that your heart rate is low, but he has no symptoms. But in most cases, his heart rate is between 60, 64, 65, okay? At times, he thinks his heart skips a beat. That's the clinical history, but in general, he's well. So he just comes to his GP surgery and they arrange a 12-lead ECG. So anyone would like to have a shout as to what they're looking at? Send a text.
Ventricular bigeminy.
Ventricular bigeminy. Okay, good call. What you're saying is ectopic beats. Yeah, ventricular ectopics. So let me point out these ones with P, QRS, and T are normal rhythms. P, QRS, T, P, QRS, T. But these ones, which are the broader ones, they're occurring every alternate beat, and these can be called premature ventricular contractions, premature like PVCs. You can call them ventricular ectopics. But when they appear in a certain pattern, okay, the word bigeminy or trigeminy refers to a pattern, because ectopics can appear on their own in isolation. They can also appear in bigeminy pattern, as if every alternate beat is a ectopic, or they can be trigeminy or quadrigeminy, like every third or fourth beat. So going back to the clinical history, why is the smartwatch saying that he's bradycardic? What's happening here is these ectopic beats are very weak clinically, so you don't feel them. Neither do the pulse oximeters or the smartwatches. They don't pick them up. So they are going to think that the heart rate is half of what it actually is. So this is often a diagnostic conundrum. Patient looks well, heart rate is low, but nothing is happening. So it's very important to look at the ECG in these cases. So take-home message here is that ectopic beats can cause false bradycardia. Okay, that's important to remember. Be wary of cases where heart rate suddenly drops, but patients have no symptoms. Pulse monitors or manual checks will not pick them up. On clinical assessment, they may even feel like atrial fibrillation, which is irregularly irregular. So it's very important to compare with 12-lead ECG. The challenge we face as cardiologists is we want to give them beta blockers and calcium channel blockers. But the nurses or junior doctors or trainees or GPs, they might panic. They might think, hold on, have you gone mad? This patient's heart rate is 33 and you're telling me to give beta blockers. How can I do that? The answer to that is this is false bradycardia. This is not true bradycardia. Once you start treatment, the ectopics suppress and paradoxically, the heart rate actually comes up. Okay, so that's the take-home message. Right, let's look at this ECG for a minute and see if someone can tell me what they think is going on here. Anybody so far?
Bass rhythm.
Bass rhythm.
Bass rhythm. Why do you think you're saying that? Can you seeing these spikes? Yeah.
Spike. Yes.
Spikes. So often there's only one spike. But here probably you're seeing two. You know. But yeah, bass rhythm. What else? What about the QRS duration? Do you think the QRS is broad or narrow? And if it's broad, then you're talking about bundle branch blocks. Is this left bundle branch block or right bundle branch block?
Somebody in the chat saying broad QRS.
Broad QRS, that is correct. It is broad and it's bundle branch block. And if you look at it now, I'm not going to details of bundle branch block because we don't have too much time, but I'll summarize. This is left bundle branch block pattern. Okay. What I want to tell everyone is left bundle branch block people can worry about. Is this ischemia? Is there something wrong with the patient? Just to reassure everyone, most of the paced rhythms are left bundle branch block. Okay, so don't worry, because you're pacing the right ventricle, you're not pacing the left ventricle. So there is delayed conduction from right to left, which presents on the ECG as left bundle. So every paced ECG will have a left bundle, but there are some exceptions.
So
Okay.
just for the participants, you can unmute yourself. So you just
Okay.
have to unmute yourself and you can speak. Somebody said in the chat, we are muted, but you are muted, but you can unmute yourself. You don't need my permission.
Okay.
Okay.
But as long as you unmute, then please don't forget to mute again after that. Yeah. Okay, let's do this ECG. Just a question here. I've got somebody who's admitted with a collapse who has a pacemaker, but this is the ECG on admission. Do you think the pacemaker is working is my question. There's no poll with this one. There's a similar poll coming later on, but anyone wants to shout out, do you think the pacemaker is working? Who thinks pacemaker is working and who thinks pacemaker is not working?
I think he has narrow-based QRS complex, so
correct.
That may translate that to the fact that the pacemaker is not really doing its job.
Not doing its job. Okay. Anybody differs from that one, or anyone who agrees with that one? If not, there are two more.
I think it's working, as we can see the spikes, but it may be like not synchronized or need to be checked.
Oh, okay. Do you think this is a spike? Yeah.
Yeah.
No, this is not a spike. This is basically just a change of lead. It's going from lead 3 to AVF. Okay. So these things are just on the ECG printout. They are not spikes. Okay. Okay. Don't worry. This is an ECG with no pacing spikes, and we don't have the answer yet. But don't worry. The next two ECGs, hopefully we'll get through it. This ECG, let's have a look. Let's assume it's the same patient. After a while, he has this ECG. Can we now see pacing spikes? Yes. But can you see it all the time? They're there.
It skips in the middle somewhere.
There's some middle, yeah.
Then it's not pacing.
So put the question up now for ECG 7, Mansoor.
Yeah, okay. Yeah, here you go.
Please answer this one. Do you think the pacemaker is working? I like it when there's a split, you know. If everyone gives the same answer, there's no fun. Okay, let's show. A lot of people have answered. Show us the results, Mansoor. So there's a almost equal split. 40% saying yes, almost 40% saying, or just over saying no. Some saying don't know. Okay, that's fine. I'll pause here. We'll come back to it in a second. Okay, stop sharing, please. I have one more ECG to show. Look at this one. Another patient, I would say, with a pacemaker who's come in with a collapse. Similar story. Can you see pacing spikes? You can see pacing spikes, right? These are spikes. Put up the question for ECG 8 again. Let's see what people think now. Okay, a lot of participation. That's good. Let's share the answers. We've got 80% answers. So this time more people are saying that it's not working and some are saying it is. So let's stop sharing, shall we? Right, let me show you one learning point here. But that's why I put these three ECGs together. This is a normal paced rhythm. How do pacemakers work? In pacemakers, there's a minimum setting below which pacemaker will not work. So if the device has been set to pace at 40 beats per minute, if patient's own heart rate is 50, it will not pace. So on this ECG, we cannot say whether pacemaker is working or not because patient's heart rate is around 50. And maybe he does not need pacing at this stage. So just because pacing spike is not there, it does not mean that it's not pacing. Okay. Next slide, you had intermittent pacing because it missed out some of them. Now here you might think pacemaker is working throughout, but then it's not working. Same principle applies. Maybe patient's own heart rate was high enough at this stage. This is his own heartbeat. It has got P, QRS, and T. Maybe pacemaker is still working, but it's just not need to pace. But at this ECG, there are some spikes which are not followed by QRS. See? So this spike is followed by QRS, but this one isn't. This is pacemaker malfunction. So you don't always need to pace. Absence of pacing spike does not mean that it's not working. Because why is it important? Often junior doctors, when they're clerking patients or when they see patients being admitted through A&E, they start to panic about pacing spikes not being seen. So don't worry about it because it's possible that pacemaker is set in such a way that it will not function unless the heart rate is below a certain range. So absence of pacing spike is not malfunction, but pacing spike in the wrong place or pacing spike not followed by cardiac cycle is malfunction. Okay, so that's another take-home message from these 4 ECGs. Right, let's see another one. Now, the next 2-3 minutes, I just want to show you a couple of ECGs about young people or people who are athletic. I was lucky enough to work with athletes about 8-10 years ago and went around the country doing ECGs and heart scans on lots and lots of athletes, national and international. So there are certain ECG anomalies, and I call them anomalies rather than abnormalities, which are commonly seen as a normal finding in young, healthy, athletic people. And that includes sinus bradycardia, very marked sinus arrhythmia, first-degree heart block, left ventricular hypertrophy, axis deviations, atrial enlargements. I'm not going into too much detail here, but partial right bundle branch block, occasional ectopics, and a phenomena called early repolarization. These changes can be seen to be normally present in athletes, and they can, that's why the title of the, this whole symposium was Weird and the Wonderful, because I'm going to show you some wonderful examples. And the extent of ECG changes depend on age, athletic activity, their body size, their gender, ethnicity, and genetics. For example, an Afro-Caribbean marathon runner may have a very different ECG from a 60-year-old Asian carom player, carom board player, because the amount of physical activity is very different. So on that note, I'm just showing you an ECG of a 20-year-old professional rugby player. I want you people to tell me, what are the abnormal findings in this ECG? I mean, there are lots of things here to comment on. I'll start off with the first one, that the heart rate is at the lower end. Heart rate is about just under 60, so he's got sinus bradycardia, okay? What else do you see in this ECG? You see very tall QRS complexes, if someone hasn't picked it up yet. Very tall in V5, V6. See, they're even overlapping each other, and deep in V1, V2. If you add the two,
LVH.
this is left ventricular hypertrophy, yes. What about ST elevations? Does he have ST elevations anywhere?
ST elevation in V3.
V3, even and more. V2, V4, slight V5, V6. What about inferior leads? 2, 3 AVF?
Yeah.
This looks like scooping ST elevation, isn't it? Like the one you describe in pericarditis. So this notching at the end of QRS with upsloping ST elevation, that's called early repolarization. This is a resting ECG of a very healthy individual. He's got no cardiac symptoms. This is athlete's heart. Athletes have LVH, they have bradycardia, this J point elevation or early repolarization. This is not ischemia. This is normal ECG. So I just wanted to show you some other extreme of normality. Now, I said this is an Afro-Caribbean, this is a Caucasian, as an English rugby player, okay? This is a real ECG, by the way. I'm going to show you another real ECG. Have a look at this one for a minute. I hope you all will say this is abnormal. Is that correct? There are lots of abnormalities here.
Yes.
What's the most marked abnormality on the ECG here?
T-wave inversion in C2 and C3.
Yeah, a bit of ST elevation as well. ST elevation and deep T-wave inversion, isn't it?
Yes.
Yeah. Quite an abnormal looking ECG. I can tell you, I gave a copy of this ECG to this athlete and I said, keep it with you because somebody might mistakenly thrombolize you. This is an Afro-Caribbean marathon runner who runs marathons for GB, Team GB, okay? This is a resting ECG of a healthy individual at the peak of his athletic career. Because of athletic activity, the genetics, the cardiac remodeling, they sometimes throw off very abnormal ECGs. And that's why an expert needs to be interpreting these ECGs. I would definitely say this patient needs a referral to cardiology though. You can't just look at the ECG and say, yeah, it looks fine. You might just be an athlete. You have to rule out heart abnormality. They need echo, they need MRI. And after that, you can say it's fine. Nothing, we couldn't find anything. It's just because you run a lot, okay? On the contrary, if they have symptoms, now if I say a 30-year-old pitches up to a clinic and says he gets palpitations and syncope, I want you to look at this ECG. I'll just go back once. You've seen left ventricular hypertrophy here. You've seen T-wave inversions as well. And I'm telling you that these are normal people. Nothing wrong with their heart. But now I want to show you something which again has marked T-wave inversions and left ventricular hypertrophy. Look at this, how tall the QRS complexes are, how deep the T wave. There's ST depression as well. Before I ask you what may be wrong with the patient, is there any other question you want to ask from this patient?
Excuse me, doctor. In ECG can I assume that this patient has got lateral MI?
This one?
Yeah, yeah.
Lateral what? Lateral what? Sorry.
Lateral ST elevation slight.
He's got it. I agree with you. V4, V5. There is ST elevation. I completely agree with you. But as I said earlier, ECG on its own means nothing. This patient has no chest pain. He's healthy. He's 25, and he runs marathons. So
family history of sudden cardiac death.
Not in this one, but here. So yeah, this one says I've got no family history. Nothing to worry. You go to this one. He says, oh yeah, hold on. My cousin died after being on a treadmill. So what are you thinking here?
Okay.
Well done. Okay. Well done. So this is what I wanted to point out. Athletes, ECG, and cardiomyopathies, they can mimic each other. But the differentiating factor here is there's a lot of ST depression, very deep T wave changes, and these changes are in V4 to V6, which is rather unusual, inferior lateral. In athletes, if you develop ECG changes, the T wave changes, they're usually anterior. Okay, that's something we've learned with experience now. Anterior may be an athlete, inferior lateral, unlikely to be normal. It's probably pathological until proven otherwise. Okay, but yeah, this is an ECG of someone with hypertrophic cardiomyopathy. I just need 2 more minutes. Am I okay with time there, Mansoor and Naseem?
Yeah, I think yeah.
Okay. Has Yawer joined yet?
Yes.
I think he is,
okay, that's fine. So I'm just going to take 2 more minutes and then hand over to him. Let's have a look at this ECG. And there's no clinical history with it. I just want people to look at it and shout out if any abnormalities they have picked up. I wish I had more time. I could teach how to look at axis, because you need to look at axis in this one. I mentioned earlier.
I have to bring you back again, Saqib.
Of course, no worries. You need to look at R wave progressions.
Right axis deviation.
Right axis deviation. Well done. Someone said that. What else? Look at V1 to V6. What do you think about the R wave progression? Is it there or is it not there?
Poor R wave progression.
Poor R wave progression.
Yeah.
Low voltage.
Yeah. AVR.
Low voltage.
Low voltage as well. AVR is positive. AVR is normally negative, isn't it?
Yeah.
So what's happened here?
Wrong placement.
Wrong placement of ECG. That's a good thought. Okay. Let me help because we're running out of time. Imagine from V1 to V6, the QRSs are becoming smaller and smaller. Do you agree?
Yeah.
That means the heart or the leads are moving away from the heart. So when you have right axis deviation, yes, positive R wave in AVR, negative in AVL, loss of R wave progression, this is dextrocardia. In other words, the leads are in the right place. The heart is in the wrong place. You understand what I'm saying? Yeah. And if you compare that with this ECG, look, the AVR is again positive. You do have right axis deviation, but you've got intact R wave progression, which means the heart is in the right place. The leads are in the wrong place. Okay, so this is lead reversal. You got it? So difference between dextrocardia and lead reversal, you will see positive AVR, you will see right axis deviation, but R wave progression will be intact in lead reversal, whereas R wave progression will go away in dextrocardia. On that note, just to conclude, the ECG interpretation, gets better with time. It's all about experience and pattern recognition. See as many ECGs as you can. You can be your own best teacher sometimes. Just make an interpretation before going to someone senior. But do remember, you treat the patient, you don't treat the ECG. Take your time to go through every ECG. Even if the diagnosis is right there in front of you, pretend as if you're thinking about it, just like a driving test, and follow a certain pattern. And just remember, all anomalies are not abnormalities. Thank you very much for listening to my talk here.
Thank you so much.
Okay, so we have, thank you, Saqib. We have our next speaker, Dr. Yawer Saeed is here. Yawer, can you hear us? Please go ahead.
Yes, I can hear you. Thank you so much, Naseem, and everyone for joining us in this talk. Hopefully, we'll be able to teach some of the basics of the ECGs. So let me just share the screen. Can you all see my screen, guys?
Yes.
Okay, so let's just start without further ado. I think we would leave about 10 minutes after the presentation finish, so that all of you can ask questions. So let's just start with a simple one to start with. Okay, so in here, I want all of you to participate. So it's all going to be an interactive session. We are going to discuss about different ECGs. And what basically I want in this 20 minutes for all of you to follow a pattern of a scheme of looking at the ECG. So anyone who are interested in reading ECGs can unmute themselves and see and tell me what they see. So don't go to the diagnosis. So just explain what you see, starting with the basic methods of looking at the rate, rhythm, axis, and then so on and so forth. Anyone can go. Don't worry, it's not. We are all friends here. We are not going to judge you.
P-wave inversions in V2 to V6.
Okay, so very good, Naseem. That's excellent. I think if you see how you would find out the rate here. So a simple thing is obviously is this. Do you think this is tachycardia or bradycardia? So just eyeball it. What do you think? Do you think this is a fast heart rate or a slow heart rate?
Normal heart rate.
Normal heart rate. Okay, very good. So do you think this is regular or irregular?
Yeah, it doesn't look regular to me.
Okay, very good.
I think it's not regular.
So it's not, it's a normal heart rate, but it's not regular. So if it's an irregular rhythm, how would you calculate the rate if the machine doesn't give you at the top of the screen? How would you do it? So simple method is actually, this one is almost around 6 seconds. The whole strip of the ECG is almost about 6 seconds. So if you count all the QRS complexes and then multiply it by 10, you'll get your answer. So this is a normal heart rate. The rate is around 70 to 80 beats per minute. Okay, what else? So rate we go, so we think that this is, the rate is about 70 to 80 beats per minute. The rhythm is irregular. But do you think this is a completely irregular rhythm, or do you see a pattern to it?
By the way, if we count all the QRS complexes, there are 13. So if you multiply it by 10, that becomes 130.
Sorry. This is a 10-second strip.
Okay, that's fine.
Okay, so who is going to, so do you think this is a pattern to it, or do you think this is just completely irregular? You don't see a pattern to it at all? So look at the rhythm strip here at the bottom. So look at the rhythm strip at the bottom of the screen. What do you see?
No pattern. I don't see any pattern. This is, I think, it's like
very good.
There's no. There's like no like Mobitz type 1, Mobitz type 2. Doesn't look like that. It's irregular. It is irregular.
It's irregular, and there is no pattern to it. And so what things then come to the mind immediately if there is no pattern to it and the rhythm is irregular?
Maybe atrial fibrillation, right?
Sorry?
The irregularity is irregular itself. So maybe like atrial fibrillation.
So what are the things that comes to your mind if you think about it? Irregularly irregular rhythm. What is the most common irregularly irregular rhythms that you see? Very good. So atrial fibrillation is one. What are the others? What are the other differential diagnoses of an irregularly irregular rhythm?
Atrial flutter.
Very good. So atrial flutter with variable block can also result in irregularly irregular rhythm. There are other differential diagnoses to it as well, which is multifocal atrial tachycardia, obviously, and then we go down to atrial tachycardia with variable block, which is not just atrial flutter as well. So this is, so irregular rhythm with a narrow QRS has not had that many differential diagnoses. Okay, now comes the third. So you look at the rate, you look at the rhythm, and now you're looking at the axis. So how would you calculate the axis?
By looking at lead 1 and AVF.
Lead 1 and?
AVF, I think.
Very good. So lead 1 and AVF or lead 1 and 2. Can you guys all see me at all or no?
We can't see you, but we can see the ECG.
No, sir. Yeah, well, you just need to adjust your camera a little bit. Because
you need to adjust camera slightly.
Adjust your camera, yes.
We can see the top of your head. Yeah, that's it. That's better.
That's better.
That's better? Okay.
Much better.
Okay, so really sorry. I think the camera is causing some trouble. So basically, there is 2 thumbs up sign, if you guys all can remember it. Let me just see if I can make it a bit better. So, 2 thumbs up sign means if both thumbs are up. Let me 1 minute. So 2 thumbs up sign means if you both lead 1 and lead 2 are positive, or both or lead 1 and AVF are positive, it's normal axis. If lead 1 is positive and your either lead 2 or AVF is negative, is left axis deviation. And if lead 1 is negative, is right axis deviation. Right axis goes to if both lead 1 and lead 2 is negative. So basically, both thumbs are up. If you can give, looking at lead 1 and AVF, if you can give them thumbs up sign, then you'll say, oh, okay, fine, this is normal axis. But as soon as the axis is one of the leads are negative, then you have to think about axis deviation. And for simplicity's sake, I remember only one, that if lead 1 is negative is almost always right axis, and it can be extreme right axis. But if the other lead is negative and lead 1 is positive, then it's left axis deviation. Okay, so we looked at this. Now come to the PQRS. Okay, what do you think about the PQRS here? How many P's do you see? And which leads, in which lead do you think the P waves are visible? Easily visible, let's put it that way. Okay, so the best leads to look at is lead V1, okay? And the other one is lead 2, 3, and AVF. So the inferior leads and lead V1. Okay, look at lead V1 carefully and see what do you think. What do you think about lead? Okay, what do you think about lead V1? What do you think about this squiggle at lead V1? Anyone?
It's some like sinusoidal type of pattern.
Very good, excellent. So keep looking at lead V1. I'm going to give you some other clue. What about this one? Do you think there's a P wave here?
Yes.
Very good. What about here?
Barely visible.
Okay, what about here? Easily visible?
Yes.
Yeah, there's.
So there are definitely more P waves. And if you, obviously one P wave is just around here. Can you see my mouse or a thumb here? Yeah. So this is a P wave. Obviously, there is another P wave here. Then there is P wave embedded in the QRS. Then there is another one here. And then if you look at the inferior lead on your rhythm strip, you'll see definite sawtooth pattern here. So this is actually a very good ECG in which the rate is almost around less than 100 beats per minute. But actually, this is atrial flutter. And that's why you see these T wave inversions in the inferior lead, in the lateral leads. And also you see the ST segment depressions here. So basically, this is not ischemia. This is actually an atrial flutter. And looking at this sawtooth pattern, typical atrial flutter. So obviously, we can discuss at length about typical and atypical flutters, but let's leave it at that. So what we want you to do at the end of this 20-minute session is to develop a scheme of looking at ECGs. What's the rate? There's different methods to it. You can divide the RR interval. But regular, if there's a regular rhythm, obviously you find the QRS on the big tick line, and then the other one becomes 300, 100, but that's obviously a crude method. Irregular rhythm, obviously you just have to calculate everything and then multiply it by 6, and then you give your answer. Then look at rhythm. Is it irregular? There is a pattern to it or not? If it is, what is the P wave morphology looks like? We'll talk about a little bit more on the other ECGs, and then the PQRS relationship. Remember, in the 2 thumbs up sign, axis. So why the axis is important? I think the axis is important for 2 very important reasons. One, obviously, is it tells you the wave of depolarization that is spreading across the heart. And then it tells us from where, if there is an abnormal rhythm, from where it is being generated. So the axis becomes very important, especially in hypertrophy, especially as the Saqib was talking about the hypertrophic cardiomyopathy. And then intervals, the QT intervals, the QRS durations, and obviously the other intervals are important as well. Most of the time we forgot about the QT interval and QRS duration. And then the special characteristics. So if you look at all this, the diagnosis will eventually comes to you. I always say that the ECG, in ECG, there is never a spot diagnosis as in medicine. There's very few ECGs where you can accurately diagnose. Even the experienced electrophysiologists take 5 to 10 seconds before they decide what this ECG looks like. And unless you have a method to it, it's very difficult to understand. So special characteristics, if there is any hypertrophy, if there is any ischemia, the QRS duration is wide of more than 120 milliseconds. And then I put this inherited cardiac conditions there because we were looking at the rare and wonderful, but this is important. Okay, let's move on. Okay, so this is a 12-year-old girl who has got mild shortness of breath, and the BMI is 23. It comes to a routine ECG. A general practitioner has seen it and asked for an ECG, and this ECG comes to you for reporting. Okay, what do you see? What do you see here? Anyone? Just have a go.
Sinus tachycardia.
Okay, very good. So one thing we established here, this is sinus, this is tachycardia. Okay. So again, don't go for the diagnosis. So tachycardia is fine, absolutely wonderful. So tachycardia is good. Now, then if it's a tachycardia, do you think it's a regular tachycardia or do you think it's an irregular tachycardia? So we are going, a tachycardia rate is around about 100 beats per minute, slightly more than 100, 110 beats per minute. Okay. So do you think it's a regular rhythm?
Yes, it's regular.
Yes.
Very good. So it's a regular rhythm and we all agree on it, and it's the RR interval and equidistance. We can map it out. Now comes the axis. What do you think about the axis?
Normal axis, positive in 1 and AVF.
Yeah, the axis looks fine.
The axis looks fine. The axis is good. Now look at the P wave morphology. Is the P wave upright in 2-3 AVF? So the morphology now becomes important. The P wave originates in the sinus node, which is in the right atrium, which is in your top right chamber of the heart. So if a P wave is being originated in the right atrium, it travels down towards the inferior leads. And as you know, that any depolarization, if it's happening towards the leads, if the wave of depolarization is traveling towards the lead, it will be positive. If it's going away from the lead, it will be negative. So inferior leads, okay, that's very good. Then you look at the inferior leads. So the P wave is upright here, which is positive in 2-3 and AVF. So it becomes sign that it is generated in the top chambers of the heart. Now, what I want you to look at is what is the PR interval here?
Around 0.2 milliseconds, I think.
Yeah. So do we expect this in a 12-year-old girl? In any GPs, especially the pediatric guys. So usually the AV node is very slick in somebody who is a 12-year-old. Okay. So it's rare to see this. It almost comes down to like a first degree heart block, and that is actually this ECG is being reported as first degree heart block, nothing else. Okay. Now I want you to focus a little bit on the other leads. So look at lead 1 and look at AVL now. Okay. So tell me where do you see the P waves in lead 1 and AVL? So this is obviously QRS. This is P wave. What about this one?
P wave is inverted.
Very good. And it is inverted. Absolutely wonderful. So in here in lead 1 and also in AVL, you feel that the 1 and AVL are what leads? Lateral leads, yes? So do you think that you expect the P waves in lead 1 and AVL to be negative in a normal ECG?
No.
Or not?
They should be positive normally.
So, wonderful. So yes. So the P wave, the 1 and AVL looks at the lateral portion of the heart, and here you see it inverted, and obviously it's away from the right atrium. So if in a normal individual or a normal girl, the P wave should be upright or positive because it should be traveling towards these leads. The wave of depolarization in the atrium should be traveling towards these leads, but it's not. Okay. So wonderful. So with what does it mean? It means that this is not a sinus tachycardia. It is a tachycardia, but it is not a sinus tachycardia. And then if you look at this now, this is a Holter which has been done on this girl. So what's happening here? Just focus on the top rhythm strips. Okay, these are the rhythm strips. Look at this, what's happened here. So you have two P waves which are very close to each other, almost around like 300 beats a minute. And then you had a little pause. And in this Holter, this little pause tells you, oh, this lady has got an atrial tachycardia. So this is actually wonderful, which being diagnosed in somebody who has a pretty normal looking ECG, if you just go for a spot diagnosis. Okay, so that's very important. I think the message if we can give you here is ECG is never a spot diagnosis. Always make sure that you go through your pattern and routine before you make a diagnosis. So this lady is actually got into tachycardia, and this is after the ablation. Just look at the ECG in lead view, in P waves in lead 1 now on here. Okay, can you all appreciate it?
Yeah,
Yes?
they're positive.
Yes, this is positive. This is upright in Imperial Leads, and so this little girl actually have dilated cardiomyopathy because of atrial tachycardia, which was then ablated and results in complete resolution of symptoms. So this is wonderful. Now, so this is something that again comes in weird and wonderful thing. 15-year-old boy, recently while exercising, presented in the ER. Okay, I could not find one of my own, so I had to make one out of the literature. Okay. So what do you see here? So again, don't try to go to the diagnosis. Just go for rate rhythm. If it's a tachycardia, bradycardia, go through your scheme. See what do you think. What do you think it is?
Rate,
so
the
try
rate
with
is
the
very
rate.
high.
Is it tachycardic?
Yeah,
do you think?
it is very high, and the interval is not regular as well, I think.
Excellent, very good. So it is, the rate is extremely fast and it's irregular. So again, the irregularity makes you think, oh, is this atrial fibrillation as we have seen before? Is this atrial flutter with a variable block? Is this multifocal atrial tachycardia? But there is something in this one as well. Can you see any P waves here? Look at lead V1.
Exactly. I can't find any P waves, so I'm thinking that.
Very good, excellent. So you cannot find any P waves. That's beautiful. Look at the QRS. How does the QRS looks like? Is it broad?
Looks
is it
complex,
narrow?
less than 0.12 seconds.
It looks broad.
Yes. So someone says narrow. Yes. And this is absolutely perfect. Somewhere it looks narrow, like here. Look at the AVR. It looks a bit narrow here, but in some it looks very wide. Okay, so you have wide QRS and you have narrow QRS as well. Okay, now, so wise QRS, no P waves, irregular rhythm. So one thing we have to establish here, this is again looking very irregular, so it has to be atrial fibrillation. Now we go through the nitty-gritty of why the QRS looks wide in some and not wide in others. Okay, so I want you to focus on the lateral leads here. Okay, so look at V4, V5, and V6. Okay, so we'll go for each individual QRS. Okay, look at this QRS. What's happening here? What do you think about this? If you all can see my mouse, what do you think about this part of the QRS?
I'm thinking it's a sort of QT, is it QT prolongation or something?
What do you think?
R wave.
So yes, it's a tall R wave, but what do you think the initial part of the R wave, is it slightly slurred or not? Okay,
Yeah,
fine. Look at this one. Can I convince you or not?
Yeah, there's no significant downsloping, I think. Just
Very good. So there is no S wave, there is slurred upstroke of the QRS here. If you look at more carefully now here in the inferior leads, look at this one. Okay.
Is this
a
delta wave?
Yes, wonderful. So this is a delta wave and this is atrial fibrillation. So this is something which is called atrial fibrillation. So it is an atrial fibrillation in somebody who has got full Parkinson-White syndrome, and you ablate the pathway here, you save a life. Okay, so this is wonderful to look at. Very easily missed, but again, if you go through your routine, you will come to the finding. Always look for these special circumstances here. The other thing is, the wonderful thing about ECG is you can actually locate where the pathway is by looking at the axis. So lead V1 is positive. And by analogy that we looked at, so V1 is a right-sided lead, okay? So if I say where this QRS complex is being generated from, whether it's the right side of the heart or the left side of the heart, with V1 being obviously the right-sided, what do you guys would say?
It's going to be towards the right, because if it goes away, then that's going to be positive, isn't it?
So it goes away from V1, it's going to be, V1 is the right-sided lead. If it goes away from V1, it will be negative. Because it's coming towards V1, it has to be generating away from the right side of the heart. Okay, so it is the left side of the heart. Now, we're looking at the inferior positive part. It's the left side, we make it sure by looking at lead V1, and then if you look at lead 2, 3, and AVF, we can actually go through that it is generated in the left lateral position with AVL being negative again. So the lead is going away from. So this is one of the rare and wonderful pre-excited ECG. I don't know how much time I have, Naseem.
And I think we're almost there. Yeah, where we've only got.
Okay, not long now. So I just wanted to show you this.
Please.
Okay, so not long, only 2 minutes. Couple of minutes. I have to show you 2 ECGs again. One of the rare and wonderful. 27-year-old male, first evaluation in a migrated country. Okay, anyone? Shout out. So first thing is obviously your rate, right? Rate is fine, looks okay, looks to be a normal rate. Okay, a rhythm. If you look at the rhythm, it seems like it's a regular rhythm. Okay, there is some spikes here, which obviously I hope you guys can notice it because it's very blurred a little bit. But you can notice it here. So it seems like a paced rhythm, seems like an atrially paced rhythm because the spikes after the spike, you can see the P wave if you notice it carefully here. Now we established that this is obviously a regular rhythm, looks to be an atrial paced rhythm. What do you think about the axis here? Any axis deviation? So thumbs up, lead one is up, AVF is negative. Yes? So it means that there is some axis deviation or not. There is some axis deviation. So if AVF or lead 2 is negative, this is left axis deviation. Okay. Okay, now I want you to focus on the QRS. So QRS, what do you think about the QRS? Is it broad or narrow or not?
Broad.
Anyone got something? Broad. Yes, broad. Good. Now focus on this one. This is a broad, looks like a broad QRS. Okay. What is this one here? And you see T wave inversions across from lead V1 down to lead V5. And remember what Saqib says, if it is a normal ECG, the T wave in athletes, the T wave inversion is usually only in the V1 to V3. Once it's progressed beyond V4, V5, it's not normal. So
yeah, but you have 1 minute.
Okay, yes. So you have something at play here. So this one I wanted to show you. So look at, concentrate on this one. This is an epsilon wave. This is T wave. Yes, as also in V4 and V5. This is a patient with erythrogenic right ventricular cardiomyopathy. So remember this little squiggle. This is epsilon. And finally, this one. Okay. So this is the spot diagnosis. Who's going to diagnose this one? So look at this one here, just on your right side of the screen. So PQRS, what's happening here? Look at the QT.
Prolonged QT interval.
Excellent, very good. So this is very, very much prolonged QT interval. And this is what happened to this. So this is a spot diagnosis. Who's going to shout out? What is it? So this is torsade. Okay.
Torsade, sorry.
So this is torsade in somebody with a long QT interval caught on the holter. So this lady actually comes with syncopal episode. Rare to get this on the holter, but we do see this very often in this part of the world, the abnormalities that we caught on the holter. So this is somebody who's 27 who's got a long QT, and this happens, and that's why she's being recent. Okay, that's about it. Thank you. And we are ready for questions. Hopefully you have enjoyed this presentation.
Thank you very much. Thanks, Yawer. Thank you.
Thank you, Dr. Yawer. That was really helpful. Thank you, Dr. Saqib, as well. And thank you, Mansoor.
Thank you. We will just get both the presenters on board, and please do feel free to answers or ask your questions directly to our presenters. Excellent presentation, amazing. I really kind of actually enjoyed it and learned a lot. Just a refresher course for me. So well done, both of you.
Mansoor, I just wanted to ask a question.
Yeah, of course, yeah, of course.
About this ST elevation business, because I know there is a lot of emphasis on chest pains in the diagnosis and evaluation of cardiac patients. So if there is no chest pain and you are seeing an ST elevation, now obviously Saqib mentioned there are normal variants, there are anomalies. It can be normal in athletes and so on. So if we see a patient who is diabetic or who is elderly, and we know that these patients may not have chest pain, and you are seeing this widespread ST elevation. So, I mean, what should you do? Should you check troponins then? Or should you say, no, it cannot be an MI because there is no chest pain, so I will take it easy? How would you go about it? Because we sometimes do see these ST elevations, but patients are completely pain-free. Anybody, Yawer or Saqib?
Yawer, do you mind if I take it briefly first?
Yeah, absolutely.
Okay. No, well done.
Your part of the deal.
No, Naseem, this is actually a very good question, very relevant question. We shouldn't forget that diabetics can have silent MI. They often don't have chest pain because of neuropathy. First question I normally ask whenever I'm asked about ECG is, why did we do the ECG? If this ECG was, let's say, done because an HGV driver just went for a routine employment check, I will just stop there and say, that's fine, don't worry. But if someone says, this patient came for an ECG because the last few days he's been having some indigestion, or he's getting slightly out of breath, or at times he's a bit sweaty, he doesn't have chest pain, but, or he just feels odd, then I will think carefully. The other suggestion I give is comparing the ECG with an old one. If there is an old one to look at, compare. If the changes are new, then likely something has happened in the meantime. But if the changes have been persistent, even though in the past, like 2 years ago, 5 years ago, then it is unlikely for them to be anything acute. That's how I would take it forward.
And sometimes patients forget as well, because I see a lot of dementia as well. They won't remember.
Yes, you're right. And that often happens with people who are often found on floor. Patients present found on floor. In retrospect or anecdotally, I can say that often they have raised troponins or creatinine kinase because they've been on the floor, they're dehydrated, muscle injury. It's a two-edged sword. It might be because they fell to the floor because something happened to the heart. But anecdotally, the chance of that happening is very low. In most of the cases, whatever you find on ECG or troponin is a secondary phenomena after being on the floor for a long time. So troponin can actually throw us off tangent there. I would treat them holistically. If they're very elderly and frail, it is sometimes dangerous to know that their troponin is raised, because they will bleed to death when you start treating them with blood thinners.
Yeah.
I think that's very important, that in elderly, never always think that a troponin rise is due to ischemia. Okay. A VT can give you a little troponin rise in somebody who's got a ejection fraction of 25%. It's very easy. Atrial tachycardia can give you a troponin rise. So yes, absolutely. Especially in elderly, if it does not give you any history, usually there is just momentary loss of consciousness. And they say, oh, it's just a mechanical fall. And you find a raised troponin and you thought, oh, it's, and you start treating with dual antiplatelets. In the next minute, what happened the next day, that the hemoglobin fell quite significantly. So yes, I think always in elderly with syncope and a troponin rise, always think that it might be something else as well.
A question for me, Naseem, if may I actually, to both you and Saqib. I've got two questions. The first question is about troponin. So obviously troponin has been there for decades, and I'm sure it's one of cardiologists' biggest headaches, actually, all these troponins in CKD patients or dialysis patients or patients where other causes could be literally looked into, and especially when the patient had no chest pain. Is there any marker, do you think, in the future that will be replacing troponin? Is there anything that we should be looking at that would actually be an ideal marker for or replacing troponin, would be kind of literally more sort of specific, I'll say sensitive to kind of actually these MIs? And the second question is about procedural. Is that how you pronounce it? Is another antithrombotic. What's its role, and do you think that would be kind of actually replacing ticagrelor? I know it's given in combination with aspirin. And who are the patients? What's the criteria for using procedural compared to your standard dual antiplatelets? Thank you.
I'll take the second one first, then move to the first question. So regarding antiplatelets, the three options on the market these days are clopidogrel, prasugrel, and ticagrelor. Clopidogrel has been there for about 10, 15 years, or maybe slightly longer. It was used for a very long time. Prasugrel and ticagrelor are also a similar chemical compound. The only difference with ticagrelor is it's in the active form. So it does not go through liver metabolism. It's active as soon as you take it, so it works quicker. Between prasugrel and ticagrelor, there's a lot of debate. There's a lot of guidelines changed recently. There's one or two only studies which have shown prasugrel being slightly better than ticagrelor in certain set of patients, but there was some selection bias there, and there is no right or wrong answer there. I usually say whatever is available in your trust. If you're going with prasugrel, stick with it. If you're going with ticagrelor, stick with that. But stick with whatever is there. Don't try and mix it up. What happens sometimes is patients are given clopidogrel in the ambulance, then they come to A&E, they're given prasugrel, then cardiologists change it to ticagrelor. That's dangerous. You're changing one to the other. So whatever has been started, probably persist with it. However, prasugrel and ticagrelor both are better than clopidogrel. Between ticagrelor and prasugrel, if they're diabetic, in some studies, prasugrel was better. But again, it all depends on how the study was done. head-to-head comparison across the board has not been done. So in most cases, we're using ticagrelor. Some centers or some European guidelines have moved towards prasugrel as well, based on 1 or 2 studies recently.
Okay, that's really helpful. Thank you for enlightening us. Thank you. And what about troponins?
Oh, yeah, sorry, I forgot. I think most sensitive troponins are coming. The newer assays are highly sensitive troponins. There may be new markers out there later. The issue with these markers are they are more sensitive rather than specific. So you're right, it causes more headache, and Yawer would agree. You'll see more false negatives, false positives.
Yeah.
So they're helpful in ruling out at an early stage, but once ruled in, it's very difficult to rule out then. So the best replacement for any marker, in my opinion, is a good clinical history.
Okay, yeah. I remember actually in medical schools we used to read about the CKMBs and all that. And I know it's a bygone era now. We don't even bring that into consideration anymore. Yeah.
I think the problem is that once these tests are available, they have been used indiscriminately on everyone. When they got tested, they obviously tested in patients with chest pains. And then it's obviously easier to exclude chest in patients with chest pain. So when obviously, if we remember, when the troponin is coming, we thought, oh, it's going to be very specific. And CKMB and the others are obviously not that specific. Because when they used it indiscriminately in almost everyone, this is not how they got tested and got approved. So the more sensitive the test is going to be, the more, unfortunately, a non-specific it will be. It's just look at what happened with the D-dimer, obviously, when it starts with pulmonary embolism, and then now, obviously, almost it becomes a test of exclusion rather than inclusion. So I think probably, I think with high sensitive troponin, and I think there are various ways in which you have to do it twice, and we are trying, I think most of the people are trying to see if you separate them out by 6 hours apart, the high sensitive troponin, if there is a change, become more sensitive markers. So there are multiple papers on it in which people have looked at the high sensitive troponin about 6 hours apart and feels that if it's more than 100, I don't know what, if more than 100, it becomes more sensitive or specific for cardiac chest pains. But again, if you use it in a wrong population, it becomes very difficult to do.
Okay.
Can I add one more thing, Mansoor?
Yeah, of course. Yeah.
This is mainly for those people who work at the front line, as in an A&E or clocking patients as junior doctors. We in the tertiary center, when we get referred an acute ST elevation MI, we get excited about it. Okay, that's the most sexist thing we do. Okay, but when people ring us and say, "I've got this gentleman with anterior ST elevation MI and he's got troponin of 5,000," the first thing I think of is they've already wasted 2 hours. So when you wait for troponin result in an ST elevation MI, it basically tells me that you missed it. Either patient presented late or you did not recognize early enough, because ST elevation MI does not need troponin, does not need chest X-ray or CT chest or CT head. They need to be in the cath lab now. Okay, so it's just something to bear in mind when you're on the front line. Don't wait for troponin in ST elevation MI. I'm just specific for that. And be mindful. If you tell a cardiologist a troponin result with ST elevation MI, then we know you missed it already.
Really helpful, important point there. Any other questions? Let me just double check the chat box, and then I think we are good to go then.
So there is some question on the chat box. I just repeated for everyone's sake. Please kindly elaborate the significance of inverted P waves. Then somebody asked, P wave inversions in lead 1 and AVL. Can you explain this again? So it's basically being looked at. So inverted T waves in lateral leads, which is 1 and AVL, if it happens, it means that the rhythm is not originating from the right atrium. Because if it's originating from the right side of the heart and 1 and AVL being the left lateral leads, you expect that the P wave in 1 and AVL is positive, which is not in this girl's case. Because it's originating in the left side of the heart, it is negative in 1 and AVL, as we discussed that if it is being originated on the left side of the heart and is going away from it, which is going towards the right-sided leads, then obviously it becomes negative in one NAVL, or the lateral lead, where you can V5, V6 be the inferior anterolateral leads. So that's the significance of the inverted P waves in one NAVL. With the same analogy, if you look at the P waves in 2, 3 and AVF. So if 2, 3 and AVF are positive, it means that it's generated in the top chambers of the heart. If it's negative, it means it's generated in the inferior portions of the heart and it's going away from the inferior loops. So hopefully that answers the question. Okay.
Okay, I think. Any other questions? If you would like to unmute yourself before we call it a day. I can't see any questions, guys.
No, I don't think there are any questions.
Naseem, yes, go ahead.
No, I just would like to thank both speakers. I think excellent talks, very good feedback I received. So the recording of the session should be available on our YouTube channel very soon. And we will share the details of the next upcoming next month's session in various other forums. So thank you all for joining. And I will share the certificate link in the chat box. So you can just copy and paste this in your browser and it should be able to work. Mansoor, can you copy and paste in the chat?
Okay, let's have a look.
Yeah.
Resend it to me or?
Yeah, I sent it to you there.
Okay, let's see.
Admins, are we okay to leave?
Yeah, it's okay. So,
yeah, we're just sharing the link.
Yeah, and I'll do the certificates for you and Yawer.
Okay.
I'll email it.
Okay, so
thank you.
Everyone, here's the link for your CPD certificate. Please click on this link and then save your certificate.
Thank you everyone.
Thank you, Mansoor, Naseem. It's a pleasure. Hopefully,
and thank you. Welcome back, and thank you for coming back, Yawer. Inshallah, next year then.
I must say, thank you for putting me before Yawer. He's such an expert in ECG. It would have been difficult for me to come after him and outperform him. So thank you.
Thank you guys. Thank you so much.
Thank you. Bye-bye.
Saqib is always humble. Thank you so much.
Thank you. Bye-bye now.
Thank you. Bye.